Our cleft and craniofacial project is on Opitz G/BBB syndrome, and this is by Lauren Bush and Kirsten Wagner.
Opitz GBB syndrome is an inherited condition that affects the features across the midline of the body. This was named after Dr. Opitz, and the G and the BBB are the families that were first affected. There are two types of Opitz GBB syndrome, that is X-linked and autosomal dominant.
The X-linked type is caused by a mutation in the M1D1 gene on the X chromosome, and this gene produces the midline 1 protein that is responsible for microtubule binding, and the normal function of this protein allows for activation of key elements of the cytoskeleton and induction of cell migration. And mutations of this gene cause deficits in mitosis through cell division and migration of cellular elements. And this is most commonly found in males, and it affects about 1 in every 10,000 to 50,000. And then the other type is autosomal dominant, and this is caused by a deletion of 22q11.2, which is chromosome 22. And it is responsible for the production of cytospin A stabilization, and it is important in cell migration of facial features, and that is likely why this mutation has cleft lip and palate. Deletion of 22q11.2 is estimated to affect about 1 in every 4,000, but the incidence of autosomal dominant Opitz G/BBB syndrome is unknown, and the diagnosis can be made through microarray test, molecular genetic testing, which is gene-targeted testing, and comprehensive genomic testing, which is exome or genome sequencing, and it can be seen in utero or up to 6 years old before being diagnosed.
Okay, so now we are going to cover some hallmark characteristics of Opitz GBB syndrome. So you are going to see craniofacial deficits, developmental delays and/or intellectual disabilities, laryngotracheoesophageal anomalies, genital deficits, and then the less common symptoms are anorectal malformations and cardiovascular deficits. It is important to note that both types of Opitz GBB syndrome present with nearly identical symptoms and features.
Craniofacial defects may be present in 50% of affected individuals, and they may vary per person. And the common craniofacial defects that are seen are ocular hypertelorism, which is an abnormal increased distance between the eyes. There's also prominent forehead and widow's peak, cleft lip and palate and submucous cleft, bifid tongue and bifid uvula, wide nasal bridge and interverated nares, which are upward turned nostrils, making them more visible from the frontal view, encephalocele, which is brain tissue that is covering membranes, and its covering membranes protrude through an opening in the skull, often seen at the back of the head or in between the forehead and nose, and this is caused by failure of the neural tube to close completely during fetal development. There's also bilateral low-set prominent ears, cytosis, and long philtrum. And females affected present with isolated hypertelorism and only rarely present with other abnormalities.
So now we are going to talk about something that we commonly see with Opitz GBB syndrome, and that is developmental delays and/or intellectual disabilities. This occurs in about half of the affected population, and it may present with neuropsychiatric disorders, which is going to be some delayed motor skills caused by agenesis of the corpus callosum and cerebellar structures. These symptoms are usually consistent with autism spectrum disorder, so you may see a crossover there. It also can cause shortened attention span, learning difficulties, and speech difficulties.
The laryngotracheoesophageal defects include laryngotracheal diastema, which is also known as laryngotracheal cleft, and this is a gap between the upper airway passage, which is the larynx and possibly trachea, and the esophagus, which in normal development, the airway and esophagus come from a common tube, and this can also be present with recurrent respiratory infections, pneumonia, dysphagia, and may possibly require a tracheostomy.
With Opitz GBB syndrome, we see a lot of genital defects. This is going to affect about 85% of males with the syndrome. You can also see hypospadias, bifid scrotum, and cryptorchidism. The less common symptoms are anorectal malformations, which is an imperforated anus, or cardiovascular deficits, so congenital heart defects.
So some medical complications and impacts of the diagnosis with voice would be resonance and intonation, which is affected due to the velopharyngeal insufficiency due to cleft palate, and this would be a defect in the seal of the velopharyngeal sphincter. In feeding and swallowing, there would be difficulty with feeding and swallowing secondary to the laryngotracheoesophageal defects. Executive functioning and cognition would be affected by the neuropsychiatric disorders and the corpus callosum abnormalities. Expressive language would be affected by the neuropsychiatric disorders, clefts, and the laryngeotracheoesophageal defects. Receptive language would be affected by also the neuropsychiatric disorders. Speech sound production would be affected by the cleft palate and submucous cleft, and that would cause hypernasality, which would affect the consonant sounds, and this is because some consonant sounds require a complete seal of the velopharyngeal sphincter. There would be difficulties with breathing due to the laryngeotracheoesophageal defects, and like I said, they may require a tracheostomy. There would be genital and reproductive system difficulties, and this would be difficulties urinating and reproducing due to hypospadias and the cryptorchidisms. There would be cardiovascular system defects caused by congenital heart defects, and then there would also be hearing complications, and this would be a risk of hearing loss due to the cleft lip and palate.
The SOP's role for assessment and treatment with Opitz GBB syndrome. So there's obviously a lot here. We're going to kind of hit the key points and explain a little bit. So the SOP can refer to surgical professionals if needed, referral to an audiologist for a hearing evaluation if needed. They can treat for resonance, intonation, and speech sound production secondary to cleft lip, palate, and submucous cleft. You can have them treat for feeding and swallowing secondary to laryngeotracheoesophageal deficits, treatment for expressive language, receptive language, and cognition secondary to developmental delays and intellectual disability. Counseling, this one is obviously bigger because this is so important. Parents, family members, stuff like that might have a pretty hard time coming to terms with everything that's involved with Opitz GBB, so counseling is going to be a really important aspect for the SOP and providing additional resources about it. The SOP can also assess the individual's feeding, swallowing, oral and written language, oral and written comprehension, speech sound production, resonance and intonation, etc., and correlate with other professionals on the patient's case.
So with this syndrome, there are many surgical interventions that can be done to improve the quality of life for the individual. So there are cleft lip and palate and submucous cleft surgeries, and these would be most effective at an early age and in the first few years of life. There's also nasal deformity surgery, and this would correct the collapsed nasal valves. There's midfacial hypoplasia surgery. There's lip reconstruction for the wide-set lips. There's reconstruction surgery for the pinoscrotal hyposplasias. There's surgical treatment for medically significant laryngotracheoesophageal abnormalities, and there's surgical repairs for the congenital heart defects.
These are just going to be all of the sources we use to find all of this information.